Okay, so again, we're going to talk about endoscopic drainage of cholecystitis, shifting paradigm. Here are my disclosures. So the take-home points are gallbladder disease, as you know, is traditionally managed surgically, but non-operative approaches to gallbladder drainage consist of percutaneous approaches and endoscopic approaches. We tend to use the non-operative approaches in patients who have severe cholecystitis, those with advanced age and/or multiple comorbidities. Remember that in the spectrum of symptomatic cholelithiasis, acute cholecystitis is but one of these. And so while this talk is focused on acute cholecystitis, we also have to remember we can intervene in other situations as needed for symptomatic gallbladder disease. Also, as a reminder, I'm sure everybody's aware that the cause of calculus cholecystitis is impaction of a stone into the cystic duct, which leads to tension in the wall, ischemia, and cholecystitis. This slide is not meant for you to read it, but it's important to realize that there's grades of severity of cholecystitis ranging at the bottom from very mild to very severe. And so while we say, oh, we can put stents in for cholecystitis, right now it's unclear how well we can perform successful therapy in patients who have severe cholecystitis, also sometimes known as hemorrhagic cholecystitis, or if they have a perforated gallbladder. So the patients endoscopically that we're going to target with cholecystitis are those with grade 1 and 2 cholecystitis. We talked about the options of medical therapy, surgery, percutaneous drainage, and endoscopy. We're all familiar with laparoscopic cholecystectomy as being the gold standard for treatment of gallbladder disease. But let's talk about the endoscopic approaches. So there are two basic endoscopic approaches for treatment of cholecystitis or symptomatic gallbladder disease. One is transpapillary, so cannulation as you would for an ERCP, selectively entering the cystic duct, and placement of a stent. Usually we're dealing with double pigtail stents into the gallbladder. The other option that's being utilized more frequently is the placement of a luminal opposing metal stent, usually from the duodenum to the gallbladder for cholecystoduodenostomy. Oops, sorry. So transpapillary drainage, we already talked about the techniques. The advantages is that it can be performed without a sphincterotomy. It can be used when the EUS approach is not ideal. That is in patients with large volume ascites or those who have contracted gallbladders where there's not a very good target to approach with EUS. The disadvantages are not only traversing the cystic duct, but actually sometimes specifically getting your catheter into the cystic duct can be quite challenging. And because the cystic duct is small, we really only can put small diameter stents, usually 5 or 7 French stents, which can be problematic in terms of needing, both the ability to really drain the gallbladder effectively in patients who have cholecystitis, but also the occlusion and need for repeat procedures. There are many series available on transpapillary drainage. Almost all of these are from expert centers. Technical success is about 90%, and clinical success 90 to 95%. It's been shown to be very useful in patients with cirrhosis as definitive therapy and as a bridge to transplantation. There's concern about doing transduodenal drainage in the gallbladder in patients that might undergo liver transplant. And specifically in the cirrhosis group, their need for intervention appears to be lower than expected based upon stent patency. The other thing is that it can allow internalization of external drains, meaning that if a patient came in and underwent a percutaneous procedure to drain the gallbladder, but yet they don't go to surgery, you can go back in and place a transpapillary stent and then remove the percutaneous drain. Here's an example of a patient who had cholecystitis, one of my patients. You can see there's a prophylactic pancreatic stent we got in. There was no initial visualization of the cystic duct, although you can see here maybe a tiny nubbin of cystic duct. We were able to finally get into the cystic duct with the use of a sphincterotome, because the sphincterotome will lean or orient toward the right side of the patient. Most of the takeoffs will be toward the right side, but not always. But then you can see the challenge once you're in the cystic duct is actually negotiating the cystic duct. I usually use for these hydrophilic guide wires, and eventually you get a guide wire deep, and then again, double pigtail stent into the gallbladder. EUS guided drainage, again, is really something that's taking off quite a bit. Just to refamiliarize yourself, we go through the lateral wall, the duodenum usually. If we're going to go through the duodenum, others have gone through the stomach. I prefer to almost exclusively go through the duodenum for a variety of reasons that we can talk about later. We can either use forward viewing linear echo endoscopes or the traditional oblique echo endoscope to do these procedures. You're probably all familiar with the main luminal opposing metal stent on the market, which is not FDA approved at this time for gallbladder drainage, but is anticipated that in the near future that FDA approval will be given for this device for gallbladder drainage. Here's a video demonstrating. You can see this is a gallbladder that doesn't look to have a tremendous number of stones. We advance into the gallbladder. This was done with the initial guide wire technique. Most of us now are performing freehand, where we just burn straight into the gallbladder. But you can see deployment of the inner flange inside the gallbladder, and then we will deploy the outside as well. I almost always place a double pigtail stent through the axio stent or the luminal opposing stent, although there's some debate about that. EUS drainage, as I mentioned, can be done through the stomach or the duodenum. Advantages, there's a variety now of luminal opposing metal stents as small as 6 millimeters, ranging all the way up to 20 millimeters, with lengths anywhere from 8 to 15 millimeter saddle lengths, depending on the stent. It can allow then direct gallstone intervention. So some endoscopists prefer to go in, whether the same procedure or later on, drive in and actually do lithotripsy and clear the entire gallbladder of stones and then remove the stent. Others, I tend to replace the luminal opposing metal stent after 4 to 6 weeks with double pigtail stents and leave those in indefinitely. Disadvantages are it can preclude laparoscopic surgery, particularly if you have a severe adverse event. Those patients are probably not going to be managed if you have a bad perforation with a laparoscopic surgery. It certainly can be difficult when the gallbladder is contracted, although there are things we can do to put saline in to make the gallbladder larger. And most of the adverse events occur because of stent misdeployment. So operator experience is obviously very important. This is a recent article looking at EUS guided gallbladder drainage versus laparoscopic cholecystectomy for acute cholecystitis, a propensity score analysis. And the lead author has been very, from Hong Kong, very active in this field of EUS guided gallbladder drainage. And basically they looked at 30 patients, not many in each group, that underwent gallbladder drainage versus laparoscopic cholecystectomy. Clinical success, 93 versus 100%. 30-day length of hospital stay was similar in both groups, longer than you, longer than you would imagine. Adverse events were similar in the groups. Obviously, re-interventions were needed in both groups. Unplanned admissions similar. So really similar outcomes, although again, small retrospective study. This same group has a randomized trial ongoing of EUS guided gallbladder drainage versus laparoscopic cholecystectomy. Those results should be out hopefully by the end of this year. This is also a systematic review recently in GI endoscopy of the EUS guided transpapillary percutaneous and drainage. So all three modalities, percutaneous on the left, transpapillary and luminal opposing metal stents. You can see technical success was actually highest with transpapillary drainage, which is interesting. Clinical success, you can see here adverse events were similar. Need for reintervention was, as not surprisingly, highest in the percutaneous group, as well as unplanned readmissions. Recurrent cholecystitis was high in the transpapillary group. Last thing I'll mention is that the EUS approach is also useful for internalization of percutaneous drains. Again, these are patients who a percutaneous drain was placed with the idea that they may go for cholecystectomy, but in fact, they never went for cholecystectomy, and there's surprisingly a large number of those patients floating around. We were the first to describe using luminal opposing metal stents to allow those patients to then have their drain removed. On the upper left, you can see the gallbladder after instilling fluid into the gallbladder through the percutaneous drain. Here's the luminal opposing metal stent. Here's the end of the procedure with a luminal opposing stent here, a plastic stent, and then the percutaneous drain. And usually you can take the drain out the same day as long as the percutaneous drain has been in more than 4 weeks. So in conclusion, cholecystectomy remains the treatment of choice for good operative candidates with milder gallbladder disease or milder cholecystitis. Endoscopic therapy is useful for long-term therapy in port operative candidates, though certainly reinterventions may be needed and often are needed when transpapillary stenting is used. Transmural drainage, I believe, using luminal opposing metal stents is increasingly performed. I believe will likely become an accepted alternative to percutaneous cholecystostomy and cholecystectomy in selected patients. Thank you.